Are you excited about the new technology? Because from manual surgery, now we are reaching out to the robotic surgery and all that.
Imagine we have to go between the rib space.
Yes.
So I can't put my hand inside.
No.
In order to reach that part, I have to make all that cut. And that is how the role of minimal invasive surgery or robotic surgery came into picture. So we applied the stapler, and when we fire the stapler, it cuts and staples. But because of the thick tissue, the staple line gave away. Nearly 1.8 million deaths happen annually because of lung cancer. Hemoptysis, meaning blood in cough, is never a common symptom. But the worst part of it is also a symptom of lung cancer. So I operated on that patient, and this is hardly 2 months back. And the very next day, she was walking in the hospital, and she has been doing extremely well at her age of 75.
Today we open the doors to a world where every heartbeat is a story, every breath is a battle, and every cut of the scalpel is a quiet prayer for life. Sitting with me is someone who walks that thin line every single day. A thoracic surgeon, a person who has seen lungs filled with hope, lungs destroyed by choices, lungs fighting for a second chance. This is not just medicine, this is courage stitched with compassion. Today, we are not just talking about surgery, we are talking about life and the miracles hidden inside the human chest. So we welcome Dr. Belal Bin Asaf, Director, Institute of Chest Surgery, Medanta, Noida, Gurugram, and other states. So, Dr. Belal, welcome to this episode of Lung Cancer Awareness Month. Tell us about normal lung diseases and lung cancers, how we can differentiate all this.
I'll start with the process that the lung cancer itself, why it is so important to talk about it. See, this month itself is a lung cancer awareness month. And what I, as a thoracic surgeon, see, and particularly when you talk about lung cancer, most of these patients unfortunately come to us at a very advanced stage. So let's say I see 100 patients of cancers in my OPD, then only 10 to 15% of the cancers that I see, cancers of the lung, are in early stages only. Most of these stages otherwise are in advanced stages. So 80 to 85% of lung cancers that present to our country and in fact globally also are diagnosed at a very late stage. And the reason for that is the question that you asked is, how do you differentiate the symptoms of normal lung diseases from lung cancer? So here lies the problem with lung cancer. Lung cancer has symptoms which are very non-specific symptoms. And unfortunately, the specific symptoms either are not present or come at a later stage when it is already late. But there are certain symptoms that you must remember. So everybody sometimes in their life will face some form of lung diseases. So they may have cough, they may have difficulty in breathing. But if this cough is persisting for a certain period of time, so let's say you have a cough which persists for 3 weeks. No cough should persist beyond 2 to 3 weeks. So if it is persisting beyond 3 weeks, please get yourself evaluated, because this could be a symptom of chronic lung disease, one of which is lung cancer. The other part is lung cancer may present as a pain, a focal pain at one point of chest. So some patients come to me saying that they had pain in the chest, but they ignored it as muscle pain and other kind of pains. But if this pain is something new and it has been persisting for some time, you should always consult a doctor and get a chest X-ray done to rule out if there is any major lung disease. The other aspect is unexplained weight loss. Now, if anybody is not trying to lose weight and is losing appetite and there is a decrease in weight, then again, that's not a good sign, because you're not trying to reduce the weight, but it's happening automatically. Therefore, there must be a reason behind it. So any cancers can cause that, and similarly, lung cancer can also cause weight loss. Now we come to certain very specific symptoms. Now these specific symptoms are like cough with sputum, which has blood. So blood in cough is a very, very specific symptom. And it's almost never normal to have blood in the cough. And therefore, you should always get it evaluated to the point to rule out that this is not lung cancer. So, as I told you, chronic cough, which is persisting for more than 2 weeks, any blood in sputum, any unexplained weight loss, any chest pain, which is focal local chest pain happening over and over again over 2 to 3 weeks time. And another important sign is new onset breathlessness. So, for example, there is an elderly gentleman who's walking 4 kilometers every day, and then for the past few weeks, he has been feeling breathless on walking just 2 kilometers or 1 kilometer. That's not normal. There has to be some reason for it, and therefore it needs to be ruled out. Now, if you look at all these symptoms, these are very common symptoms that are also there in other lung diseases also. And that is why when we try to compare and give you an answer that are there any symptoms which really separate lung cancer out from other lung diseases, so that's not the case. A high index of suspicion is required. And therefore, those patients who are at high risk, for example, those who smoke, those who have had a family history of a cancer in their family, including
So is it
cancer,
genetic also?
it can have a genetic component also. And therefore, these patients, if they have these kind of symptoms, they should not ignore it. Get yourself evaluated. Majority of the times, it will be nothing. But if it is something, then it needs to be detected early.
Okay. So if there is a person, healthy person, and he comes with an episode of hemoptysis.
Yes.
So if it is not TB or any disease, what it is exactly?
Mr. Yasi, you very good question this is. Now, as I said, hemoptysis, meaning blood in cough, is never a common symptom.
Okay.
It has to be a specific symptom because of certain disease. Now, when you talk about the causes, the commonest causes in our country are because of infection. So, if anybody develops TB, he can have hemoptysis. If anybody has pneumonia, he can have hemoptysis. There are other certain infections like fungal infections of the lung. These cannot have hemoptysis. Then sometimes patients who have been treated and cured of tuberculosis have telltale signs within the lung which have structural damage, and that also can cause hemoptysis or blood in sputum. But the worst part of it is also a symptom of lung cancer. Okay. So any patient who has blood in sputum should be evaluated in detail by a person or a doctor who is specializing in lung care.
Okay. If we talk about thoracic science, is it a new branch? Because as a layman, if we know about pulmonology, a chest specialist, but what is exactly about thoracic science?
So I'll briefly tell you about how it started. So it started from the word cardiothoracic and vascular surgery. In common language, when we talk about thoracic surgery, you always CTVS surgeon ke paas jana hai, ya they always talk about that CTVS group. So when the specialty started, it started as cardiothoracic and vascular surgery. So essentially what thoracic means is it is a surgical branch which takes care of all the organs inside the chest, except for the heart and the major blood vessels. So there is a heart in the center of the thoracic cavity, and from there arise certain blood vessels. Excluding these, all the organs inside the chest, which include the lung, our windpipe, which is the trachea, the division of the windpipe, which is the bronchi, then the food pipe that is there, which is allows us to take food inside, that also comes in the thorax. These ribs and the muscles, these are also the part of the air. There is a muscle called diaphragm which separates the abdomen from the chest and is also a respiratory muscle. These are all organs which come under the domain of thoracic surgery, and any surgical problem of these diseases, what a thoracic surgeon does. Now, as you said, it has been a specialty which has been there for a very long time. But it started as a combined specialty where a surgeon who used to do cardiac surgery, which means heart surgery, was also
he would have also doing the same thing.
But nowadays, things have so much specialized that these are in itself a separate specialties, and most of the major and advanced hospitals will have all these three components separate. So there'll be a cardiac surgeon who looks after heart and the major blood vessels.
Exactly.
There'll be a thoracic surgeon like myself who looks after the organs that I've told you. And there is a vascular surgeon. Now, what is a vascular surgeon? Is this one who looks after the blood vessels which are in the different parts of the body.
So it makes a collateral.
So it has now divided from CTVS to C, T, and V.
Okay.
And I belong to the T component of the thoracic component.
So, Dr. Belal, tell me, if we talk about stomach cancers, breast cancers, and lung cancers, which one is very common in that, if we talk about India in particular?
So, globally, lung cancer is the commonest cancer now. Okay. And in India also, we can divide it into men and women. So, in men in India, now lung cancer is the commonest cancer.
Mhm.
Earlier, it used to be oral cancers because of tobacco chewing, but nowadays it has become lung cancer.
Mhm.
In women, it is the third leading cancer in India after breast and cervix.
Okay.
So, in terms of commonality, it is becoming very, very common. And there are certain other things which are very surprising that I share in my lectures and when I talk to people like yourself and others. That there has been a change in the lung cancer scenario in our country. So, over the past few years, we've seen that a lot of non-smoker patients are coming with us, coming to us for lung cancer. Now, earlier we used to see lung cancer, 90% of them were smokers. Today, almost 50%
Non-smoke.
patients with lung cancer are coming with, are non-smokers. And the male-female ratio also has changed. Again, earlier it was mainly a diseases in the male. Now it has almost 40% of our patients are females. So this is the scenario that is happening, and the question that you asked, it is the commonest cancer overall. It is the most common cancer in India in male, and it is the third most common cancer in females.
Okay. So, Dr. Bilal, tell me, if we talk about 2025, there are now new technologies, AI, and rest of the things are available. Are you excited about the new technology? Because from manual surgery, now we are reaching out to the robotic surgery and all that. Where do you see the future of thoracic science in India?
Very good question, Mr. Yasir, and I'm glad that you asked that question. See, any new technology has to be incorporated into your existing self. A lot of people ask me this question that when AI came and they're scared that AI will take away your job. Usually what we say is the AI will not take away your job.
Exactly.
A person who knows AI will take away your job.
Exactly.
So, how to use AI, it's becoming very, very important. And as far as lung cancer is concerned, there are several companies and AI softwares nowadays which help us identify the high risk individuals. So, if you have a hospital software, they will dig out the history of the patient from the hospital software and they will find out who are the high risk patients. So, they will already categorize amongst your hospital base, whoever patient are coming to the hospital, they will categorize, okay, this patient might be a high risk cancer case,
Exactly.
number one. Number two, there are other softwares. For example, when you get an X-ray done for any reason, not necessarily chest. So somebody is undergoing a laparoscopic cholecystectomy, want to get an X-ray done. That X-ray is done, and we in our hospital in Noida also have that software where an AI software imagines and details examines the X-rays.
Okay.
And it finds out nodules that are probably or may be missed by the radiologist because they're so small and they cannot be. So they will do what the software will do. It will identify those nodules and it will pick up all those nodules and tell you that there are nodules in this X-ray. And then the radiologist will in detail evaluate them and realize and try to decide whether these are significant nodules or non-significant nodules. So if they are significant, they will be further evaluated by a CT
So it will make a journey a little easier.
Yes. So identification becomes easy because, the problem, as I told you with lung cancer, is that majority of the patients come at a later stages. And if there's by any means we can diagnose these patients in the early stages, the results are going to be tremendous because early stage lung cancer can be cured. Whereas later stages diseases, stage 3, 4 can only be controlled. They cannot be cured completely. So this is one part of integration where the AI is helping us diagnose the problem and detect it early. Moving on to the technological aspects, like you said, robotic surgery. So when we do any surgery inside the chest, imagine we have to go between the rib spaces.
Yes.
Now, if you can see, the rib spaces are very narrow. I can't put my hand inside.
No.
So I need to cut the skin. I need to cut the layers of tissue that are there and various muscles. And then finally, I reach the rib space and then I cut through the rib space, but then I cannot go inside because the rib space is less responsive. There is another instrument which is known as a retractor. We open the chest and that causes rib fractures and breathing mechanics change. And then finally, we are able to insert our hand and do the surgery. Now, if you imagine it this way, that the actual surgery is being done inside. So let's assume that I have to remove one part of the right lung. In order to reach that part, I have to make all that cut. The surgery has not actually started. I only have reached there. Once I reach there, then I do the surgery. Now, if I can, this causes a lot of trauma to the body. And that is how the role of minimal invasive surgery or robotic surgery came into picture, where you want to minimize that trauma of access. In order to reach the organ of interest,
Exactly.
you don't need to cut the entire chest open. And that's how robotic surgery and minimal invasive surgery came. So the first step was minimal invasive surgery. So what we did was we started making small keyhole incisions, and we place a camera through that incision, and then looking at the screen and using two long instruments, we used to do the surgery.
Okay.
Now the problem with that is, it is a good way, and still we do a lot of these procedures like that. But you imagine that, I'm using a long instrument against a fulcrum. And if I have to go down with my instrument, my arm needs to move up.
Exactly.
And if I have to go up, my arms need to go down. So this is just counterintuitive. It's not the natural movement of the body. But how do we counteract this? So how does it affect us? It affects us by increasing the hand-eye coordination problems. And if the hand-eye coordination problem is not there, it takes a long time to learn a procedure. So if I have to teach what is known as video-assisted thoracic surgery, which I'm talking about, then it will take a long time for the person to learn that thing. But if I could imagine that if I could put my hands on the tip of those instruments, just somehow miniaturize my hands and put them on the tip of those instruments, and then my hand can behave exactly the same, then all this problem of learning curve goes away. The precision increase. So robotic surgery essentially is what? It makes even smaller cuts. And there are long instruments. The tip of those instruments work like human hands. And it works on what is known as a master-slave concept. So it does not work on its own. So what I do is, just like when you play video game, you use the joystick.
Take the remote.
Whatever you do, that the character will do the same thing.
Exactly.
So it is exactly what happens in robotic surgery. There is a console. I sit on the console. I look into the viewfinder, and then there is a joystick. And the joystick is designed in such a way that when you open your fingers, the instrument will also open up. When you close it, the instrument will close. When you pull it, it will pull. So it will replicate the exact same movement that I want inside the robot. So I'll do that movement, and that movement will be replicated by the robot. So instead of this big cut, 3 or 4 8 mm cuts can introduce my hands inside, and I can now do the same surgery that I was doing open with much less trauma, more precision, because I see better. The vision is better. I see a magnified view. It's like sitting inside the chest and doing surgery. And handling the fragile structures of the heart and the lungs become much easier. And even going further than that, now what is happening is, even if I have tremor while I'm doing surgery, the robot identifies those tremors and it filters those tremors out.
Okay.
And so it becomes even more precise. In addition to that, the vision that we are seeing is a 3D vision, just like human eye. So the robot gives you a 3-dimensional vision. You can have depth perception. You can see everything. And in addition to that, as you said, AI integration is happening. Now, what is going to happen in future is that all the CT images, all the data, that will be incorporated into this robotic system. And the robotic system will then be able to tell us, okay, this is a structure that you should be careful of. This is the tumor here. You have to take this out. This is the lymph node here. It will be able to guide you real time inside the surgery where exactly the tumor is, so that your precision will increase during the surgery.
So simultaneously, it will save our time first. Second, it will help the patient in recovery also.
So you can imagine that when I'm not making that cut, and I'm just making these small incisions, all these cut, the muscles cut, the rib fractures, this is not going to happen. And the patient recovers much faster. The pain is much less. The bleeding is much less. Requirement of analgesia or painkillers are much less. Their ICU stay reduces, and overall hospital stay reduces. And also they return to their work much earlier.
Okay. Let's talk about children.
Yes, please.
We have a lot of IVF centers right now. There are IVF hospitals in view of demand, obviously. If babies are born with premature lungs, do you think that they should refer the parents and the baby to a chest specialist, or there is also your opinion important being a thoracic surgeon?
So in most of these premature babies where the lung is premature, usually a thoracic surgeon is not required.
Okay.
It's usually a pediatric intensivist, a pediatric critical care expert, or a pediatric respiratory expert is the person that they should pay. Now, wherever these kind of IVF centers are working, it is mandatory that you have either within in-house or enclosed facility a full-fledged neonatal ICU facility where the patient can be kept till that time that the lung become mature. So we have seen, and I'm sure you must have also seen so many children being born prematurely, and they are kept in incubators and ventilators for a certain period of time till their lungs become functional enough. And therefore, you need to have a good pediatric pulmonology and pediatric respiratory and intensive care sector. Most of these cases do not require
Doesn't
thoracic
it?
surgery.
Okay, Doc Sab, tell me if there is a lung tumor and you have removed it, are there any chances again that he or she may develop it again?
Yes, there is definitely. So I'll explain it in this way, that we have to identify whenever there is a tumor, it is either a benign tumor or it is a cancerous or a malignant tumor.
Okay.
When it is a benign tumor, how do we differentiate between benign and malignant tumor is the fact that a benign tumor grows at its own location. It increases in size slowly. It may press upon the other structures, but usually does not invade the structure. But it does not have the potential or the capacity to move out of its location to different areas of the body.
Okay.
Whereas when we talk about cancerous lesions or malignant lesions, the biggest difference is that the cancer cells have the ability to move away from the tumor, go into the bloodstream or the lymphatic system, and then get lodged at different areas of the body and present as tumors in different areas of the body, which is known as metastasis or stage 4 diseases in any cancer. So this is the basic difference between a benign tumor and a malignant tumor. So if you remove a benign tumor, the chances of its coming back is virtually zero.
Okay.
But still, it requires certain degree of follow-up, because if it was not removed completely, it can still come
It
back.
can still come back.
For malignant cases, it usually depends upon the stage. But even in early stages, you have to keep the patient in follow-up, because a malignant tumor can recur for a period of 5 years and sometimes even later. So any patient who I have removed a tumor which is a malignant tumor, I will definitely keep him under follow-up, because there is always a chance of recurrence. Except for very early stage disease, there is still a chance of recurrence or even in early stage diseases for lung cancer. So all lung tumors that are malignant can recur.
If we talk about a patient who visits to you, what exactly are the criteria for you to fulfill when you tell them that this patient needs surgery?
Yes, very good question. For that, you need to understand, for example, let's talk about lung cancer. This is Lung Cancer Awareness Month. And I see a lot of patients from Kashmir with lung cancer. I have operated so many patients through Kashmir, probably more than any other states that I've operated. Somehow, Kashmir has a higher incidence of lung cancer compared to other states. And when I see a patient for lung cancer, the first step is to identify at what stage it is. Okay, because the stage will define the treatment. So by and large, if you consider it, if it is a stage 1 disease means that lung tumor is restricted to the lung. It has not gone anywhere else. Stage 2 disease is where the lung tumor is either bigger in size or closer to the structures, or it has gone from the lung to the lymph nodes which are inside the lung. Now, what are lymph nodes? Lymph nodes are like police cross checking ya nakabandis. So when the tumor cells tries to escape from there, it catches the So there are nodes which are within the lung, and there are nodes which are inside the chest but outside the lung. So if it is within the lung nodes, then it's become stage 2 disease. And if it goes beyond the lung into the mediastinal nodes, it becomes stage 3 disease. And finally, if it has moved through blood to other organs, for example, contralateral, opposite side lung, it can go to the brain, it can go to the bones, it can go to the adrenal glands. If it has gone there, then it becomes stage 4.
Okay.
So for stage 1 and 2, these are the patients who usually will benefit from surgery the most, because today the single most important treatment for lung cancer and single best treatment for lung cancer is surgery wherever possible. And surgery is usually possible in stage 1 and 2. In stage 3, you have to carefully evaluate the patient. There are some patients who will benefit from surgery, but first they will receive chemotherapy and then get surgery. And there are few patients who will not benefit from surgery, and therefore they should go for chemotherapy and radiotherapy. And in stage 4, the disease cannot be cured, and no form of local therapy will help because the cancer has spread beyond. And therefore, these patients will be treated with chemotherapy, targeted therapy, or immunotherapy.
Okay. So, Dr. Sab, as you earlier said that you have operated most of the patients from Kashmir.
Yes.
Have you seen anything common in them?
So what I've seen is that I've seen a lot of female patients from Kashmir with lung cancer, and most of them non-smokers. But most of the Kashmiri males that I've seen have been smokers. We don't have that high a number that we can, come to a conclusion that these are the common factors. But I believe that there is certain exposure that is happening in the household. Either it is in the form of some smoke or something like that, which is causing an increased incidence of lung cancer in this part of the
Somewhere I read within 17 or 20 seconds, one person dies because of lung cancer in India. Is it true?
Yes. So it's not in India, it's a global.
It's
It's a global.
Okay.
So nearly 1.8 million deaths happen annually because of lung cancer. And you can imagine, if you can do the maths, it'll automatically come to that number.
17 to 20 seconds.
70 to 20 seconds. So that's a real problem. And the problem is that it's going to increase.
But डॉक्टर साहब, डू यू थिंक जैसे हम बाकी डिजीजेस को देखते हैं,
जी,
एक्सीडेंट हो गया किसी का, या कोई ऑर्थोपेडिक इशू है, या और कोई इशू है, डू यू थिंक दिस डिवीजन लंग्स का, या ये जो थोरेसिक की हम बात कर रहे हैं, इट इज अ बिट इग्नोर्ड?
absolutely ignored because there are two problems. Number one, the specialty care is very scarce. It's not available everywhere. तो हर जगह आपको एक तो thoracic surgeon मिलता नहीं है. सबसे बड़ी प्रॉब्लम हमारी जो कंट्री में है कि इनिशियल जो ट्रेनिंग हुई है सिटी वेस्ट वालों की, वो सारी की सारी ट्रेनिंग कार्डियक में हुई, थोरेसिक की ट्रेनिंग इग्नोर हो गई. तो क्यों ऐसा हुआ? बिकॉज थोरेसिक पुराने जमाने में सिर्फ टीबी और उसके रिलेटेड कुछ इश्यूज को ही माने जाते थे, तो उन्हीं को ऑपरेट करते रहते थे. एंड कार्डियक सर्जन्स वर नॉट इंटरेस्टेड इन ऑपरेटिंग दोस केसेस बिकॉज दे हैड बिगर एंड बेटर थिंग्स टू डू. तो वो सिर्फ कार्डियक केसेस करते थे और थोरेसिक को इग्नोर करते गए. तो उससे क्या हुआ कि धीरे धीरे एक ब्रीड ऑफ सर्जन्स बन गए जो कि वेल ट्रेन्ड कार्डियक सर्जन्स हैं बट नॉट सो वेल ट्रेन्ड थोरेसिक सर्जन्स. Unfortunately, in a country like India, जहाँ पे TB itself is an endemic disease, इतना common है TB, तो there are so many patients who require thoracic surgical help, and that is where it was lacking. So yes, you're very right to say that thoracic surgery has been ignored because the number of thoracic surgeons that should be there are not there, and therefore these diseases, not only lung cancer, even the benign diseases are not getting treated adequately in time because there is no available thoracic surgeon nearby. So it has been ignored for a pretty long time. But nowadays, because of the development of newer technologies, like you said, robotic surgery, minimal invasive surgery, video assisted thoracic surgery, and a lot of these new developments have again attracted now more younger generation towards thoracic surgery. So now people are talking about thoracic surgery, and you see many doctors and surgeons coming up wanting to take up this specialty.
So Dr. Belal, tell me, if we talk about India in general, how many patients would be there who needs thoracic care?
Innumerable. It's
Any data or research has
there is
been
no
done in
data.
this field?
Unfortunately, we are lacking in data from our country. Even lung cancer specific data or a thoracic surgery specific data is lacking. But as in my experience over the past 15 years or so, I go out to various peripheral cities all across North India, and I see hundreds of patients who require thoracic surgery, but have not been advised thoracic surgery or not have been given the right direction, because even the doctors in the peripheral city do not have an option where should they send the patient. So this data is very difficult to point out quantify in terms of data, but there is a huge demand for thoracic surgery cases because TB is very endemic. If you look at the benign versus infectious versus cancer, it is benign cases which are more prevalent and they are more common and they require more cases. So for example, you must have heard of a disease which is known as empyema thoracis, which is basically pus around the chest. It happens in tuberculosis. It can happen after an pneumonia. It is so common. And there are, when the pus forms, it has to be drained out of the body. So you put a tube inside, but then the next step is the lung should expand completely. Majority of the people leave it at that. The tube drains the pus, but the lung doesn't expand. The tube remains, the cavity is there still, and it reaccumulates the fluid, and the pus keeps reaccumulating for months together. Now, if these patients reach us in time, then we can
maybe things can be saved.
A lot of things can be saved. So there are a lot of patients which are there, and there is a lot of scope for thoracic surgery in India currently.
So, Dr. Belal, tell me those cases which you have already operated. If we talk about their follow-ups and their recovery rates, आप कैसे कहेंगे कि अभी तक कैसे results रहे हैं आप?
So मैं आपको एक example देता हूँ. So I recently operated upon an elderly lady from Kashmir itself.
Okay.
She's probably 74 years or 75 years old, and she had lung cancer. So they came to me, and we did now reverse back 10 years back. All such patients, अगर हमारी ओपीडी में आते तो हम पहले लोगों को, हमें अभी भी याद है हमारी ट्रेनिंग के टाइम, हम कहते हैं यार इनको घर पे रखो, आप थोड़ा आराम कराओ इनको, जिनकी जिंदगी
एज जितनी भी बची है तो
हाँ उनको आराम से गुजारने दो. बट आज की तारीख में जब मैंने उनको देखा, एंड आई सॉ दैट देयर वाज अ लीजन व्हिच आई कैन रिमूव, और चूंकि रोबोटिक एंड मिनिमल इन्वेजिव बैट सर्जरी हमारे पास अवेलेबल है और वो पूरा कट लगाने की जरूरत नहीं पड़ती है, तो आई ऑपरेटेड ऑन दैट पेशेंट, दिस इज हार्डली 2 months बैक. आई ऑपरेटेड ऑन दैट पेशेंट, and the very next day she was walking in the hospital.
Okay.
And I have been following her up for 2-3 months, and she has been doing extremely well at her age of 75.
75.
So this is a proof in itself that instead of open surgery, if you can perform, it may not be possible in all cases, but if you can perform minimal invasive or robotic surgery, the advantages and the results are very good. Now again, this patient was an early stage lung cancer. I have operated for similar patients, 60 years, 65 years, who have been diagnosed with lung cancer, and I have been following them. I have been doing OPDs in Kashmir for the last 2 years, 2 to 3 years, and before that, when I was in Gangaram Hospital, I used to have a lot of patients.
Okay.
So the longest follow-up from Kashmir, or for that matter, for lung cancer in general, is about 8 to 10 years. So the last patient I operated was in 2016. Now it's almost 9 years.
Yes.
And it's still coming to me with follow-up. In fact, I have to remove the whole right lung in that
So
section.
the recovery rates are quite positive.
Absolutely
in manner.
positive. The only caveat in that is that it has to be diagnosed early. All these cases who have done well have been early stage lung cancers.
Was there any case which is close to your heart जहाँ पे आपको जब ऑपरेट कर रहे थे then you needed also a cardiologist there, and who was that surgeon and how that case is very close to you?
We do a lot of difficult cases also. So we were once operating upon a very difficult case where it was an advanced lung cancer, and patient had received radiotherapy, and radiotherapy causes a lot of dense adhesions and makes the tissues very hard. So when we were operating upon these patients, when we remove the lung, we have to staple the vessels and cut the vessels, the blood vessels that drain into the lung. So one of the blood vessels that I was draining was, when we have a special stapler that we use. So we applied the stapler, and it is when we fire the stapler, it cuts and staples. But because of the thick tissue, the staple line gave away, and it started bleeding. Now this is a very disastrous consequence, because the vein comes directly from the heart. And if I have cut the vein and it has opened, it means the heart is bleeding.
Exactly.
And within the next 5 to 10 minutes, I have to control the bleeding. Otherwise, it will. So what we do is, that is where a team effort comes into picture. And because our hospital has a good cardiac surgery backup, so we have a surgeon, Dr. Anil Bani, also belongs to Kashmir, and now is working in Medanta. So we called him, and we were able to, sort of clamp that vessel, and we were able to repair it. So that case is a very close case, because that gentleman was an elderly gentleman, and despite all this, at one point, because of the blood loss, we had almost his heart had almost stopped, and we were somehow able to complete the surgery. And then I thought personally that no, he won't do well, because blood loss ho gaya itna, and he's an elderly gentleman. But surprisingly, that was 3 years back, and I've seen him in the OPD even today.
Okay.
So what it tells me, and what it incites me, that we as doctors and surgeons should do our level best to perform our best.
Exactly.
Let healing and life be in the hand of the Almighty.
Exactly.
Yeah.
So, Dr. Belal, as you have been working in the area of this field since very long, tell me, apart from other hospitals, if we talk about Medanta, how the treatment from Medanta is different than other hospitals?
So I'll talk about thoracic surgery in specific Medanta. So in Medanta, the thoracic surgery group is the single largest group of thoracic surgeons in one place.
Okay.
So we have 7 consultants with us, all of them trained thoracic surgeons who are doing only thoracic surgery. When I talk about thoracic surgery, we do not touch any other organs except for the thoracic organs.
Okay.
So this is one way. So when you have a good team of extremely trained individuals, nobody is perfect. Everybody is bound to make mistakes. Everybody is bound to face certain problems, certain confusions. But that is where the team role comes into picture, where the team can come together and then they can decide the best line of management for one particular patient. So even if I'm not sure about how to proceed in a complicated case, I have 6 more minds with me who will help me out and come to a conclusion. So that's one part. That is a very powerful and good team. The other thing is that we have a dedicated setup for everything. So we have our own wards which are dedicated for thoracic surgery. We have our own ICUs. We have our own operation theaters. We have our own nurses. We have our own anesthetists, all dedicated only to help with thoracic surgery patients. So when you do that kind of work day in and day out, you become very specialized in a particular aspect. So you identify problems early and you're able to solve those problems. The third aspect is that Medanta has a holistic approach. So you have all the specialties, allied specialties available with you. As I told you in the last case, when I needed a cardiac surgeon, it took me 2 minutes to get the cardiac surgeon. Many hospitals who do oncology work do not have a cardiac surgeon. And if they need a cardiac surgeon, they have to call a cardiac surgeon from a different hospital. The other thing is, I have a radiation oncologist with me. I have a medical oncologist, full-fledged department, extremely well-equipped department. And there are certain patients who may not be candidates for surgery. They may be candidates for targeted therapy.
Exactly.
And that is where my entire team. So I come along with the medical oncologist, the pulmonologist, the radiation oncologist, and also the pathologist. And we all sit together in a tumor board and decide the best line of management for a particular patient. So that is how the team and the entire one-stop solution makes it different. So you don't have to go, once you come to our hospital, you don't have to go anywhere else for completion of the treatment.
So in vivo, if we talk about team efforts, so those are there, 100% there. So you don't need anyone else from another hospital
yes,
to help you in surgery or if you need any emergencies like that. If a layman is there and he complains of an episode of hemoptysis या breathlessness हो रही है इसको या और कोई chest की problem हो रही है, where he can differentiate ki whether he has to consult a chest specialist or a thoracic surgeon. One. Second, if he is complaining of something where a chest surgeon, chest specialist will identify that he needs a service of thoracic surgeon now, should he refer him immediately?
The first part of your question, when should you go to a thoracic surgeon and when should you go to a pulmonologist? See, if you already know that you have diseases like empyema or hemoptysis and you've got a CT scan done and you know that there is a disease which is known as aspergilloma, which is a benign disease which causes hemoptysis, or you already know that there is a cancer has been diagnosed by a CT scan or something, then you need to go to a thoracic surgery specialist.
Okay.
But usually that is not the case. Usually patients go to a doctor because of a symptom.
Exactly.
And usually what I recommend is that if you have a chest symptom, which is very specific, so as I told, a cough that persists for more than 2 weeks or blood in sputum, new onset of breathlessness, chest pain, and weight loss. If you're having any of these symptoms on a persistent basis, you should consult a pulmonologist. A good respiratory physician will be able to identify those issues and connect to a doctor. The second part of your question is that, the understanding of the pulmonologist that now this patient requires surgical care and should be referred. As soon as the pulmonologist or the respiratory physician identifies a problem to be a surgical problem, then they should actually come to a doctor as soon as possible. Because what I've seen is that even when doctors have advised surgery, पेशेंट्स वो सर्जरी सुनना नहीं चाहते. दे डोंट वांट टू. देखिए, नेचुरल प्रोसेस है. मैं किसी को बोलूं कि भाई आपको सर्जरी की जरूरत होगी तो वो डेफिनेटली बोलेगा कि भाई डॉक्टर साहब कुछ करा दीजिए जो दवाओं से इलाज हो जाए. दिस इज वेयर द पीपल फॉल्टर. इफ देयर इज अ रिक्वायरमेंट फॉर सर्जरी, द अर्लियर यू डू इट, द बेटर द आउटकम विल बी. तो सिंपल डिजीजेस लाइक पस अराउंड द चेस्ट, जिसको हम एम्पायमा कहते हैं, उसको हम लोग आधे घंटे में भी खत्म कर सकते हैं मिनिमल इन्वेजिव सर्जरी से, और वही सर्जरी 6 से 8 घंटे भी ले जाती है. तो द कॉम्प्लेक्सिटी ऑफ द प्रोसीजर इंक्रीजेस विद द टाइम दैट इट टेक्स. For cancers, another thing, the cancer will spread, it will become inoperable. So the moment you realize that you have a problem which is surgical, क्या क्या प्रॉब्लम्स हो सकती हैं? देखिए, न्यूमोथोरैक्स एक नाम की डिजीज होती है, एम्पायमा एक नाम की डिजीज होती है, लंग नोड्यूल, लंग ट्यूमर हो गए, मीडियस्टाइनल ट्यूमर्स हो गए, ये सारे जो हैं थोरैसिक सर्जिकल डोमेन है। खांसी में खून आना, सांस में दिक्कत आना, नॉर्मल चेस्ट पेन होना, ये सब एक पल्मोनोलॉजी का डोमेन होता है। बट पल्मोनोलॉजी का काम है जब वो अपना इवेल्युएट कर लेते हैं और उनको कोई ऐसी चीज दिखती है तो वो रेफर करते
But then referrals becomes very important for
हैं।
them
एब्सोल्युटली,
because as soon as they will start treating them themselves, with knowing that this is a case of now thoracic surgery,
thoracic surgery.
that can create further problems.
Absolutely. That can create a lot of problems. And I've seen a lot of patients being delayed because of that. So they start assuming that this could be something else.
Exactly.
And they start treating it like that. Or the patient wants you to treat like that. So instead of forcing the patient to go and see a thoracic surgeon, they try to, okay, chalo, try karke dekhte hain. See, that is the thing that we need to talk amongst our community.
Exactly.
We need to raise awareness about this. Because problem क्या थी कि thoracic surgery हर जगह available नहीं थी।
नहीं,
तो अनफॉर्चुनेटली डॉक्टर्स के पास ऑप्शन नहीं था।
नहीं।
अब वो कश्मीर में बैठ के वो किसके पास भेजे?
Exactly.
सारे मरीज दिल्ली जाके इलाज नहीं करा सकते, तो दे हैव एन इशू। सो अनफॉर्चुनेटली उनका भी एक स्टैंड है जो वो फॉलो करते आ रहे हैं सालों से। बट नाउ सिंस दी things are available, thoracic surgery is available, opinion is available, so now we should have dialogue between respiratory physicians and ourselves, and we should create a free dialogue between ourselves. So anybody can call me and tell me I have this problem, and if I say, yo, this was
Have a
like
look on it.
surgical problem, I'll have a look and see the patient. So I think the earlier the referral, the better the outcomes.
And Dr. Saab, what was the minimum age you have operated and maximum age you have operated?
For thoracic surgery?
For thoracic surgery.
So thoracic surgery, we have operated, we tend to avoid very small children, but up to 5 years of age, I have operated.
Okay.
And elderly, the most elderly I remember is 89 years old.
So you have operated as minimum as possible and
Yes.
as maximum.
Yes.
So Dr. Bilal, tell me why thoracic surgery? There are too many branches in the medical field.
Yeah.
Was it a chance, choice, or destiny?
I think I would say it was destiny. So I was initially interested in trauma care, and I was very interested in trauma care. So I used to work in All India Institute of Medical Sciences in the trauma surgery department. There's a trauma center in AIMS, and I used to work there. I was very interested, doing a lot of good job. So there, the posting of us as residents, senior residents, used to rotate between these specialities. So what we did was I spent about 1.5 years in trauma center at All India Institute of Medical Sciences. And then I was posted in Unit 3 of the surgical disciplines in All India Institute of Medical Sciences. Now, Unit 3 in AIMS used to look after thoracic surgery. And my mentor, Dr. Arvind Kumar, whom I joined, he was the head of thoracic surgery at that time.
Okay.
He had started doing robotic chest surgery for the first time in the country in 2008. I joined him in 2010. So I was very, very interested in robotic surgery.
Was he the first mover in robotic surgery?
Robotic chest
In
surgery.
India?
Yes, he was the first mover for robotic chest surgery in India. And when I joined him, I came to know about his robotic surgery. And I was very interested in robotics because I'm always attracted to technology. And that is how, my interest in robotics brought me to thoracic surgery. And once I went into thoracic, as days passed, I became more and more interested. And then I completely dedicated myself to thoracic in that.
If we talk about health, medicine, and tech right now, do you think it will make things easier in our future?
Absolutely. So there is a very famous quote. I don't know who said that. But once a new technology rolls over you. So imagine the technology is the steamroller of the road. If you don't climb the steamroller, yani you do not take the technology,
Exactly.
you will be the part of the road. So if once the new technology rolls over you, be the part of the steamroller rather than the road. And that is why this is how technology is. So new technology is going to definitely help us. Now, earlier, a lot of people ask me these questions. Doctor, robotic surgery is very costly. You can do the same surgery by VATS also, which is minimal invasive,
Okay.
or laparoscopic surgery for that matter. And I say, yes, I can do that, but I give them two examples. One, let's assume that I have to draw something here.
Okay.
Okay. Now I give you 2 feet long pencil and ask you to draw. If you are very good at your hands, you may be able to draw, but with a lot of difficulty.
Yes.
With a lot of difficulty. Now, if I give you the option of minimizing your hands and putting it there and then draw, you can draw much better. So that is the difference between doing a VATS or laparoscopic surgery and robotic surgery. So robotic surgery gives you that extra advantage, the extra precision that is required. The cost, any new technology is costly. So when the first phone came, the Motorola phone was
Exactly.
$5,000 or $4,000. I don't remember exactly. Now you can see even a rickshaw puller has
a good phone.
has a
now.
smartphone. So technology, once it starts being used, the cost comes down and more people will start to use it. The other aspect is what I told you, the implementation of AI into the augmented reality into the robotic systems. It's much easier than doing it in minimal invasive surgery. So again, this will help make the surgery more precise, more safe, and it will guide the surgeon as to what is to be done exactly in a safe manner. So once the technology is there, it is only going to improve upon what is already existing. And therefore, today when people ask me, why do you want to do this case robotic and why don't you want to do this open or minimal invasive? I say that, if I have a straight road, I take a Maruti 800 or any car, straight road, single road, nothing, no problem. A to B point, I will reach there.
Right.
But if I have to take a turning road and I have to go in an off-roading process, which means I have to do a complex procedure,
Exactly.
then if I have a 4x4 vehicle, I will be more
That will
safe.
be good.
It will be more safe. And so this is how
Comfort
robotics.
also.
So that is how new technology is, going to help us. A 4x4 vehicle with a lot of tech and gadget will help you traverse difficult terrains. And similarly, a new technology with AI integration, implementation, and robotics will help make the surgery safer and good. So that is where the future is.
So, Dr. Bilal, tell me one more thing. If we talk about a newly married woman diagnosed with something and you have told them that she needs a surgery, can she become mother then after lung surgery?
Absolutely.
Or there are any issues?
No, not at all. So I'll give you an example. So there was this policeman we operated his wife about eight years back. Now this lady had a left-sided destroyed lung, and the problem she was having was recurrent chest infections, and she was having blood in sputum every now and then. And we had to remove the left lung completely.
Completely.
Yeah. And then this was the question that their family asked, what will happen to their married life? Now you imagine a situation where this left lung is not functional. It is actually causing damage to the body.
Exactly.
So when you removed the left lung, she is only going to be actually better than what she was. And she would be able to do her normal life normally. So even with the complete removal of the lung, people can still continue to have, both male and female can continue to have their normal married reproductive life. It is not going to affect them. The only situation, if you are having chemotherapy for some reason, if you're having certain radiation therapy for some reason, there is a time period where you are not supposed to conceive because it will have, the chemotherapy will have its effect, the radiotherapy will have its effect. But once that phase is off, you can do.
Tell us one thing which everyone should know about taking care of lung health.
So I'll just tell you a couple of things, in fact. So we breathe about 20 to 25,000 times every day. अल्लाह ने ऐसा निज़ाम हमें दिया है कि आपको और मुझे ये पता नहीं चलता कि हम 20 से 25,000 बार लेकर रहे. उसमें 10,000 cubic liters of air we are taking, cubic meter cube of air we are taking inside. 10,000. And therefore, the air we breathe is very important for us. So we have to take care of the lungs and protect it from whatever sources of dhool and dhuan. This is what I say everywhere. So you protect your lung from dhool, which is dust in any form, and you protect your lungs from smoke, which is smoke in any form, be it burning of wood, be it smoking, be it shisha, be it vape.
Any smoke.
Any smoke is bad for health. So you protect yourself from these two aspects very, very strongly. The other thing is that you have to realize that in India, these diseases are now being diagnosed more commonly. And once you are diagnosed with a problem which needs surgery, please do not hesitate to go to a thoracic surgeon and at least have a consultation, because a lot of your fear and things will go away once you talk to talk to a thoracic surgeon.
Exactly.
And finally, do not ignore your symptoms. Chest pain, cough, shortness of breath, unexplained weight loss, and blood and sputum. These are very, very important signs. Do not ignore it. If they are there for more than 2 weeks, consult a good doctor. Get it over with.
So again, early prevention is much better.
Absolutely.
If we get
Absolutely.
it as early as it is
So the simple rule is, I'll give you an example. For example, if I catch a very early stage lung cancer, so in cancers, we talk about mortality. So the 5-year survival rate for a cancer that I've detected in very early stage is almost 90%. But the same goes down to 60 to 70% in stage 2. And it drops down to 35% in stage 3. And in stage 4, it drops down to 10, not less than 10%. So you have a lot of advantage in detection and early detection of lung cancer, and for that matter, any thoracic diseases, because the earlier you detect it, the better you can control.
Exactly. Thank you so much, Dr. Bilal.
Thank
It
you so
was
much.
really very nice interacting with you.
Pleasure is
You
mine.
educated us everything about thoracic science. Maybe some other time we need some more information. We'll invite you again.
Thank you so much. Thank you so much, Mr. Yasser. Thank you.
Today was not just science, it was soul. We don't forget how many silent battles our bodies fight for us and how many heroes work behind the scenes to give those battles a chance. To our guest, Dr. Belal Bin Asaf, thank you for the honesty, the courage, and for reminding us that every breath is a blessing. To everyone listening, take care of your lungs, take care of your choices, and take care of your life. Until next time, stay aware, stay kind, and keep breathing with gratitude. Thank you all.